you like to kick us off, or would you like me to begin immediately?
I will go ahead and get started. I'd like to welcome everybody here to the PQ, the Physician Quality Reporting System webinar, and I really especially want to thank Carol O'Brien from Abbvie, who's been really working with Dave Whitcomb and myself on helping us develop some PQRS measures for pancreatic diseases. And this is part of Pancreas Fest 2015 and the academic Pancreatic Centers of Excellence. We've gone through a lot of the measures, and we've crystallized things down to some measures that we think can be used for pancreatic disorders in academic pancreatic centers of excellence. So I also want to thank Amir from the University of Pittsburgh Medical Center for helping us get the webinar through the CAPER website. So I'm going to now introduce Carol O'Brien from Abbvie, who's going to help teach us about the Medicare Physician Quality Reporting System and the value-based modifier and the impact it has on us as specialists. And they've been very successful at helping other GI specialists and getting this done for them. And so we're going to have a webinar tonight and another webinar next Thursday at the same time, and we will probably be hosting some others in the future as we try to bring in other societies such as the AGA, the American Pancreatic Association, the American Society for Gastrointestinal Endoscopy, and other societies who have given us verbal endorsement last year and this year on our efforts at trying to develop these academic pancreatic centers of excellence. So at this point, at this time, I'm going to introduce Carol O'Brien, and she's going to be teaching us about physician quality reporting system. Carol.
Thank you, Dr. Conwell. It's my pleasure to join the group this evening, and I'd like to echo Dr. Conwell's welcome to all the pancreatic disease specialists and recent attendees of Pancreas Fest who are joining us this evening. I'd also like to thank Dr. Conwell and Dr. Whitcomb for their leadership in developing this important opportunity to learn about the Medicare Physician Quality Reporting System and the new value-based modifier that will change the delivery of healthcare and reimbursement for healthcare from now into the future. This is a very important development, and we really appreciate the support of Dr. Conwell, Dr. Whitcomb, and Dr. Amir Gugal, who is helping us with the webinar this evening, as well as the leadership of CAPER and all the CAPER members who are sponsoring and supporting this event. As Dr. Conwell mentioned, my name is Carol O'Brien. I'm the Director of Policy at Abbvie. I'm a healthcare law attorney and formerly worked for about 13 years with the American Medical Association in their General Counsel's office. I think it's really fitting for the group this evening that we are discussing this dynamic change in the Medicare program and healthcare in general on the 50th anniversary of Medicare and Medicaid in the United States. And we can certainly say without reservation that perhaps this new value-based payment approach to Medicare and to other payers, as we will learn shortly, is the greatest sea change in healthcare since Medicare and Medicaid were enacted 50 years ago. So what is so dynamic, what is so critically important about this new healthcare landscape? And what we're going to be talking about is the value-based modifier. I did want to begin, you can see the screen in the first screen of the presentation. This is a very recent resource that we developed in conjunction with the American Gastroenterological Association, and this is the implementation guide that the AGA is now promoting and offering to their members with the help and support of Abbvie to really help members understand various options for reporting PQRS and understanding the impact of the value-based modifier. Now, what is the value-based payment modifier and why is it important? Well, it's a new change in the Medicare law which will now require physicians to report quality measures and to assess their cost of care, and the new basis for payment will be quality of care and cost of care. Those are the two new requirements on which all physicians across the country will be evaluated and paid. It's important to understand how this is really changing the face of healthcare, because our current system is a fee-for-service system in which physicians like yourselves are paid for any medically necessary services that Medicare and other payers deem to be medically necessary and subject to their fee-for-service schedule. What will happen now and what's different now is the fee-for-service platform will remain, but from now on, Medicare is imposing a new budget-neutral system, and you can see from the pie chart that what budget-neutral means is that physicians who don't do as well and who don't adjust to the new value-based payment modifier will get a payment adjustment, and the physicians who can adjust will take some additional reimbursement and will receive incentive payments based on the same amount of budget that their colleagues, their other physicians, will be losing ground from. So those physicians who don't do well will essentially be transferring some of their reimbursement that they would have received to those physicians who do well and adapt to this new system. Cost centers are going to be very important, and because so many pancreatic disease specialists are teaching and providing care in academic medical centers will be subject to the same scrutiny for costs that other health systems and other hospitals and provider groups will be subject to. Medicare will be looking very closely at services that are provided in a hospital setting that could be provided in a less expensive outpatient setting. So the center of care will be very important. Finally, and most importantly, all physicians, including pancreatic disease specialists, will be evaluated based on their cost of care, and that cost of care will be assessed according to the national mean standardized cost of care for all Medicare services provided by pancreatic disease specialists. So Medicare will adjust payment because they understand that physicians who are providing care in New York City and San Francisco will have more expensive practice expenses than a physician providing care, say, in Boise, Idaho. However, once Medicare adjust for those different practice expenses and for severity of patient, they will literally compare on a bell curve the cost of care provided by all pancreatic disease specialists across the country, and those pancreatic disease specialists whose costs come in at the national mean level or below will be in an advantaged position, while those whose costs are above the national mean will very likely in the future see their payment adjusted. So it's very important as we move into this new paradigm of quality and cost that all physicians really understand the implications of optimally reporting quality metrics, and we'll be talking about which quality metrics they should be reporting, as well as adjusting their cost of care according to the best possible and efficient cost approach that they can use. Now, why is reporting PQRS? And PQRS will be the new quality indicator for Medicare. So in other words, when we talk about physicians needing to have a quality score that will affect their payment, what we're talking about is the need to correctly report PQRS measures. It's very important from a Medicare perspective because the baby boomers are rapidly aging into Medicare eligibility. From now until 2030, for the next 15 years, we're going to see a very significant spike of Medicare eligible new patients as the baby boomers age into Medicare. And of course, it's important to remember that the new formula for payment will be how each pancreatic disease specialist does in terms of his or her reporting of PQRS quality measures, plus the cost of care per Medicare patient. Both PQRS quality measure scores and the cost of care per Medicare patient will equal payment starting now in 2015, because whatever you are performing or not performing in terms of quality measures in your cost of care in 2015 will be used to calculate your payment starting January 1, 2017. Medicare is just one of many payers that is making quality of care and the cost of care transparent on websites across the country. Medicare.gov has a new physician compare website, and you can go to that website now, type in your name or the names of other physicians, and Medicare will report back whether those physicians are correctly reporting PQRS measures. In the future, the cost of care for each physician, which is now available on Medicare databases, will also be easily found in the Physician Compare website. All of the other commercial payers, United Healthcare, Blue Cross Blue Shield, with its Healthcare Blue Book, all have or are in the process of building consumer-centric websites which will increasingly provide patients with transparent information about each physician across the country's quality of care and cost of care. It's very interesting to note that the Healthcare Cost Institute, which is launching this year in 2015, is a collaboration of Medicare, Aetna, and Humana, who just consolidated or merged. So Aetna and Humana are now one big payer or managed healthcare plan. Kaiser and United Healthcare, two other very large healthcare plans, are going to be collaborating on this new Healthcare Cost Institute website, and data about every physician in the country's quality and cost will be compared for consumers, for other physicians, for health systems, and for other payers who want to analyze that data. At the bottom of the screen, you can see the MicroStrategy Public Health app. This is an iPad app, and what this app has done is very cleverly taken data from Medicare Excel spreadsheets based on Medicare reimbursement and developed this very ingenious app. And if you use this iPad app, you'll be able to, again, find any physician across the country. And as you can see here, this is data from 2012 if you start at the left-hand side of the screen. But moving to the middle, you can see that this particular physician profile, this happens to be a dermatologist who was educated at Northwestern, but this profile shows that this particular dermatologist was paid about $1.25 million by Medicare for services provided to Medicare patients in 2012. This particular physician treated over 1,100 patients, providing 44 different services. But on the far right-hand side of the screen, showing a page from the MicroStrategy Public Health app, you can see that this particular physician, a dermatologist, was reimbursed about $1,100 per Medicare patient on average. But that compared with his peers, who were only reimbursed an average of $250 per patient. So this kind of data is increasingly going to be available to payers and patients across the country. The scorecard that physicians will have based on their data will often be the basis for many health plans narrowing physicians from their networks. In many cases, physicians will not be dropped from a network, but what will be more likely is that many of the commercial payers are following Medicare's lead. They're instituting value-based payment programs based on quality scores and cost. And what many of them are doing is simply, and certainly United Healthcare has been doing this with the American Gastroenterological Association. The United Healthcare and AGA has a program whereby United Healthcare will actually give preferential status to gastroenterologists who successfully report PQRS measures through the AGA registry. And we're going to see more and more of these types of collaborations in which large payers like United Healthcare, Aetna, Cigna, and others will reward physicians based on their quality and cost of care. And they will do that by tiering physicians or putting physicians who meet their standards in a lower cost, easier to access tier. Physicians that they believe do not meet their standards may be in a non-preferred tier in which they may have a much higher copay that will make it more difficult for physicians to access them. So the need to have the best available data for pancreatic disease specialists is certainly emerging as a very important requirement. We wanted to just very quickly mention that Cigna, this is an example of a case study from Cigna, and Cigna is partnering with a number of accountable care organizations across the country. This map shows the pervasiveness of the Cigna ACO collaborations that began back in 2010. But this is just one example of one payer entering relationships or contracts with accountable care organizations or other value-based physician groups. This could certainly be a large health system like an academic medical center or an integrated delivery network or health system associated with an academic medical center. But the growth of ACOs is a major change in the healthcare landscape. We now have 425 Medicare-only ACOs. All of those ACOs have at least one, if not more, commercial ACO payer arrangements similar to the Cigna collaborations shown here in this slide. And we now have about 750 different commercial ACO arrangements across the country. And all of these arrangements, again, are based on the quality and cost of those participating physicians. So what is Medicare's PQRS, Physician Quality Reporting System, for the physicians joining us tonight who may not be as familiar with PQRS? PQRS has been around for quite some time. It certainly was a program that started back in 2007, 2008. But what's different now about Medicare's Pay for Performance program is that it's now required. And physicians who report PQRS successfully will no longer get an incentive or a reward simply by reporting PQRS. Now it's become much more complex. Physicians are required to report PQRS measures. If they do not successfully report PQRS measures, they will receive a payment penalty or adjustment. Even those physicians and other healthcare professionals, the slide shows here that nurses and physician assistants are also required to report PQRS measures. So if you're part of a large health system, all of your team members will be required to also meet these standards. But now with PQRS, if you don't report, you'll automatically get a payment adjustment. And even if you do report PQRS, it will be very critical to report as optimally as possible because Medicare will be looking at a sliding scale of quality depending on whether you achieve the best quality, just average quality, low quality, or no quality at all because you weren't able to report PQRS. So what happens to those physicians who do not successfully report? Well, if you're in a group of between 1 and 9 physicians, you will automatically receive a payment cut of -2% across all of your Medicare billables starting in 2017. Physicians in groups of 10 or more, and most of the specialists joining us tonight, I'm sure, are in groups, the larger groups, but the failure to report PQRS would result in a -4% penalty. Now, some of you who are working with and part of the faculty and part of the physician groups in large academic medical centers may say, well, does this really apply to me because our large group is actually extracting data from our electronic medical records and they're already reporting quality measures for us, either as an ACO or perhaps as a GPRO, a group practice reporting option. One of the reasons we want to bring this message to pancreatic disease specialists and to all specialists is because very typically these measures that the large groups, the ACOs, and the large academic medical center health systems are reporting are very focused on primary care measures. That means that specialists may have very few measures to report that actually apply to their specialty. And it's also important to optimally report as many PQRS measures that apply to your practice as possible and to systematically report those measures. By relying on other team members to extract data for you and not be mindful of the measures that you would like to be reporting consistently and proactively, you are actually not optimally reporting PQRS data, and the more data you report and the more measures you report, the better you can support your larger healthcare system. It's also extremely important for specialists, as we mentioned before, to try to amass as much data as possible because the quality and the cost data will be your sword as well as your shield. And the more specialty-specific data you have, the better position you'll be in to promote your pancreatic disease specialty group as a pancreatic center of excellence because you'll have specific measures that apply to your specialty. The AGA, the American Gastroenterological Association, realized this several years back, and they developed several measures sets or measures groups that are distinct measures groups that apply specifically to the gastroenterology specialty. They developed a measures group for inflammatory bowel disease, and they also developed a measures group for hepatitis C. What's very advantageous about reporting a measures group is that because it's a specific set of measures aligned with a certain disease state, by reporting that measures group, a specialist would only have to report a sample of 20 patients. Now, 11 of those patients must be traditional Medicare, but the other patients could be commercial patients. You could treat a 30-year-old inflammatory bowel disease patient who is a commercial patient. So by reporting a measure set like inflammatory bowel disease or hepatitis C, it provides a great deal of flexibility to that specialist. He or she only has to report a sample of 20 patients during the calendar year, and they can report non-Medicare patients. So just to focus a little bit more closely and provide a brief review of the IBD PQRS measures group. And this is a page from the Guide to PQRS for Inflammatory Bowel Disease that Abbvie and the AGA worked on and developed and are distributing to gastroenterologists across the country right now. You can see there's 7 measures in the measures group, and these are measures that gastroenterologists are very commonly reporting typically on their patients, but may not be optimally gathering this information for most of the patients they're seeing. And I expanded the screen a little bit so you could see the measures more easily, but they include influenza immunization and pneumonia vaccination, not just for older adults. This measure has actually been changed for inflammatory bowel disease to include younger adults as well. Counseling against tobacco use. The IBD measures group also focuses on assuring that gastroenterologists are using corticosteroid-sparing therapy and that patients aren't on steroids for longer than a 60-day period, and also focusing on ensuring that testing for TB and testing for the hepatitis B virus is performed before initiating anti-TNF therapy. So these are the measures that are now contained in the inflammatory bowel disease measures group, and some of these measures are also measures that could easily apply to pancreatic disease specialist. So,
Carol?
Yeah, go ahead, Dr. Conwell.
So I would like to just pause right now before we move into the academic pancreatic centers of excellence, and with that as a background, and see if anyone has any questions for Carol at this point in regard to the PQRS measures, and have questions about what we are trying to accomplish. So we're open for questions. Okay. All right, great. So as you can see from the inflammatory bowel disease measures group, that's the direction that we want to go. I think initially we're going to be developing a flashcard with Abbvie's help. They've been very successful, as you can see, with working with the AGA. We do have Barry Kislaw's blessing. He'll be helping us work with Abbvie to get this done, and support from some of the other GI societies to accomplish this. And hopefully down the road, I think it takes more time, up to a couple of years, to develop the full measures group for submission. But I think this is the direction that we want to go for pancreatic disorders. So, Carol, thank you very much for what you're doing. Now let's move into the academic pancreatic centers of excellence and really show you what we've done in terms of the background work that Dave and I have gone through a lot of the measures and work with Carol and Abbvie, trying to crystallize some of these things down to narrow down the focus for us as academic pancreatic centers.
So to build on Dr. Conwell's point, and you can see on the screen that the work that Dr. Conwell and Dr. Whitcomb and the Advanced Pancreatic Centers of Excellence Working Group are concentrating on is developing a pancreatic disease specific measure set. Because currently, unfortunately, even though PQRS has over 300 different measures across all of the various disease states, there are no measures that currently exist that are specific to pancreatic disease. The best available PQRS measures that we have now are cross-cutting measures or other measures that are, in many cases, preventive services measures or general gastroenterology or primary care measures that do also apply to pancreatic disease patients. If pancreatic disease specialists want to optimally report PQRS, they would need to either choose a measures group like inflammatory bowel disease or hepatitis C, as Dr. Conwell mentioned, or they could choose 9 individual PQRS measures. That's the requirement to to successfully report PQRS and avoid a penalty, 9 individual measures, and those 9 measures must be reported on 50% of all of the applicable Medicare patients. So the best time to start reporting is certainly now. And as Dr. Conwell alluded to, he and the other members of the group are going to be seeking endorsement from key pancreatic disease specialty organizations, including the American Pancreatic Association, the American Gastroenterological Association, the American College of Gastroenterology, CAPER, of course, and the Society of American Gastrointestinal and Endoscopic Surgeons. I'd like to now have Dr. turn the presentation over to Dr. Conwell, unless Dr. Conwell, you would like for me to go through the proposed 2015 and 2016 quality measures options that you're now considering for pancreatic disease. So you can see those measures on the screen, and if Dr. Conwell would like to speak to those, that would be great, or I could certainly speak to these measures. Dr. Conwell, would you like to review these measures with us, or would you prefer that I do that?
Yes, I'm sorry. I was already. I was muted, so I couldn't say anything.
Great.
Sorry about that. Yeah, so we were. So these are the PQRS measures that we crystallized things down for pancreatic disease specialists. So quickly, some of these are related to pancreatic disorders, as the people on the call webinar will recognize, and some of these are really cross-cutting. So we thought screening or therapy for osteoporosis for women 65 or older could be a measure. Pharmacologic therapy for men and women age 50 and older is a consideration. Colorectal cancer screening, colonoscopy adenoma detection rate. These are things that we normally would do anyway in our offices. Hepatitis, one-time screening for HCV for patients at risk. Also, medication reconciliation. This is something that all of us are currently doing. Biopsy follow-up, if a biopsy was done. This could be appropriate for like EUS FNA. Appropriate follow-up interval for normal colonoscopy in average risk patients. A very common thing that we do in our practices. Since tobacco is very important for us in terms of pancreatic disease, tobacco use screening and cessation intervention, and also unhealthy alcohol use. Pain assessment and body mass index. Documentation of current medications in the medical record, also a very common measure that most of us are doing in our everyday practice. Preventive screening, influenza, immunization, pneumonia vaccination status for older adults. These are very easy to achieve in terms of quality measures, and you'll notice these were also seen in the IBD group. So I think what we're going to be doing going forward, we're probably going to send out, the plan is to send out a survey monkey and try to get some voting, get some buy-in from people. We're also going to get representation from the other societies, including what we did leave out on one of the slides was the ASGE, the American Society for Gastrointestinal Endoscopy, and some of the surgical societies have also said they help support us in our efforts at Pancreas Fest for this effort. So we're going to get some representation and get some endorsement from them as we go forward. So now I'm going to turn it back over to Carol to finish up the presentation.
Thank you, Dr. Conwell. And we want to be respectful of everyone's time. We know it's late in the evening, and this is a lot of material to take in, so we're going to go very quickly. And thank you again for your participation this evening. So just a quick recap. Why should pancreatic disease specialists participate in PQRS or be aware of PQRS? Well, because worst case scenario, you could be facing a significant financial penalty of between -2% or -4% that would apply to all of your Medicare billables if you're not reporting PQRS, either in your own individual group practices or if you're part of a larger system. It's very important to be aware of these quality measures and to develop the best data set that you possibly can. It's also very important to be aware of your total per capita cost, and those total per capita costs will be based on your Medicare Part A hospital expenses and your Medicare Part B physician and ancillary services expenses. So the combination of those two will equal your value-based payment modifier score. And this is a slide from CMS which reiterates that point. Now, what happens if you don't report PQRS? Well, as we've learned, looking at the right-hand side of the slide, unfortunately, physicians who don't successfully report PQRS are now subject to an automatic payment penalty. But what if you do report PQRS correctly, or you know that some of your data is being extracted currently to provide PQRS scores for your institution or your health system? Well, at that point, Medicare is going to look not only at the fact that you've reported PQRS, but they're going to look at how well you did in reporting those PQRS measures. And did you report those measures on the optimal number of patients that you could have? And did you report all of the requirements necessary in that measure? What will happen then is, on this slide you can see, and let's look at the bar chart at on the lower part of the slide. If you're in a group of 10 or more physicians and you optimally report PQRS measures, you're going to get that share of the pie or that share of the budget for Medicare reimbursement that those physicians who were not able to successfully report PQRS, who did not report optimally, will leave behind. So assuming you're reporting PQRS at the highest possible level, you would be in the high quality, that upper right-hand corner of these bar charts, and you would get a +4 factor. In other words, you would get 4 times more than physicians who had a low quality score. And moving across this bar chart to the left, you can see that if you optimally report, you could be looking at getting 4 times the payment factor of other physicians across the country. If your PQRS scores are simply average, you might get +2%. And if they're low, if you unfortunately report, but you don't report PQRS data sufficiently or well, you could still end up with 0%. The other sliding factor to consider is cost. So again, moving back to the right, even if you report optimally and you do the best you can with PQRS, you report 9 different individual measures related to pancreatic disease on all of your eligible patients, or you report a measures group, then you're in the best possible position. You would get a +4 factor, or 4 times more than other similarly situated physicians, because you are in the high quality sector. However, at that point, CMS or Medicare will be looking at your quality score, whether you get +4%, +2%, or 0. And if you get +4%, for example, but moving across to the cost axis, if your cost is low, you get to keep that +4%. But if your cost is average, moving down the bar chart, you could end up with just a +2% factor. And if your cost is high, even if you optimally report PQRS, you could end up with 0%. So this slide depicts the sliding scale of how the combination of your cost and your quality will be used to determine your performance. And this scatter dot slide shows another indicator of how you can learn from CMS. Physicians now have available to them their 2014 physician feedback or quality resource use reports. Our guide, our PQRS guide, can help you understand how to get that information from CMS. You have to go into the CMS database and actually put in your tax identification number and your NPI numbers for your physicians and obtain that information. But it is possible to get your QRUR or physician feedback report, and this shows you how you compare to other physicians, similarly situated physicians across the country in terms of your quality and cost. This slide shows you what a QRUR quality resource use report looks like, and you can see on the y-axis here that it will actually list out for you your Medicare evaluation and management services, the services performed by you, the services performed by other specialists that you may have worked with, or primary care physicians you may be working with. It will show you the cost of your procedures, your inpatient hospital cost, your outpatient hospital cost, emergency services, ancillary services, and other services including Part B drugs will all be included in the QRUR report. And this again is the data that Medicare will use and commercial payers will be using based on their own data of utilization to determine your value. Finally, I wanted to show an example of value-based payment and what to expect in the future. This is a very busy slide, and I apologize. I know it may be a little bit difficult to read, but the important takeaways here are that in April, the Congress passed the Medicare Access and CHIP Reauthorization Act, also known as the MACRA. This MACRA, this new Medicare law, permanently repealed the Medicare SGR policy that we've been living with for the past 17 years. So that was the good news. But the other news that may not be completely known by a number of physicians is that Congress and our Congress currently overwhelmingly passed this new law. And as you can see at the bottom of the slide in the blue bar that goes across the bottom, this new law that was overwhelmingly passed by the Congress, both the Republicans and the Democrats, and this is a Congress that has a difficult time often passing new laws or agreeing to anything, but this Congress, our current Congress, overwhelmingly agreed that the law of the land for the future will be value-based payment. And you can see starting on the left-hand side of the slide in 2015, physicians will be subject to payment and reimbursement adjustments based on their PQRS scores, their meaningful use of electronic health record scores, and their value-based payment, which will be based on their cost of care. This will continue starting in 2019. All three of these programs will be rolled into one program called the Merit-Based Incentive Payment System, and you can see starting from 2019 and continuing through 2026, physicians will continue to be subject to value-based payment requirements that could yield either a -4% payment adjustment or up to a +4% payment adjustment in 2019. And by 2022, that payment adjustment could be as much as a 9% bonus or a -9% loss. What's also very important in the purple bar, we can see that under this new MACRA, this new value-based payment system, that is now codified for the next 10 years and will be the law of the land that all physicians will be following, that any physician who's part of an alternative payment model, and that could be an ACO, it could be a bundled payment of some kind in which the group of physicians or the health system, the academic medical center group is taking some kind of risk or bundled payment for care, say for pancreatic disease patients, then that group would automatically be eligible for a 5% lump sum bonus by being part of an alternative payment model. So the need for physicians to be very cost careful and to provide the best quality possible will continue to be an important influencer for the future. So at that, I would like to end the presentation and open it up for any questions that any of our participants may have about any of the subjects we've discussed this evening.
Thank you, Carol. That's been really great. So we're open for questions or comments.
And
it's a quiet audience.
Yeah, please don't feel shy, because often physicians are. This is a lot of information to take in, and it's not that well understood. So please don't feel that any question is is out of order, because we've been doing these presentations all over the country, and I'm sure we've heard your question before. So please feel free to make comments, as Dr. Conwell suggested, or ask any questions.
So, Carol, when you're talking about cost, and there's a slide you have on cost toward the end. Yeah, cost and quality. So value, the term value comes in a lot. So define that for us. That's in regard to trying to minimize cost, but also having high quality. Is that correct?
That is correct, Dr. Conwell. And as you were alluding to, the term value can have different meanings, and a commercial plan that institutes its own value payment model similar to Medicare, because many of the commercial payers are now following Medicare's lead and instituting their own value payment programs, and they may have a slightly different approach, but virtually all of the payers, Medicare and the commercial payers, are looking for lower cost, and they're really focused largely on those high cost factors like emergency department visits, inpatient care. Big cost drivers right now are hospitalization, unnecessary hospitalization, of course. The readmission is a major quality metric for hospitals as a standalone quality metric, but now Medicare and the commercial payers are going to be looking very closely and comparing those physicians based on their utilization of high-cost services like hospitals. So if you are a pancreatic disease specialist and you have more patients being hospitalized or going to the emergency room than other pancreatic disease specialists, that's not going to be good for your quality and value profile, because you could be in a situation where you seem to be either overutilizing services or not providing the quality care or the best care coordination approach or team approach that should hopefully, in Medicare's eyes and in the payer's eyes, prevent unnecessary hospitalization or more preventive care that would intervene before that hospitalization was necessary. So it's a really good question, because one of the reasons that Congress and healthcare institutions are really moving to an accountable care organization type of framework is because it provides the kind of systematic clinical pathways and team care coordination approach to prevent some of the unnecessary utilization of services to be more efficient and prevent what some of the payers in Medicare see as less efficient use of resources. So the question is exactly what we're moving to, and it's going to become increasingly important for physicians to use all of the resources available to them, because this is a high bar. What Medicare and what payers are asking of physicians to implement meaningful use of electronic medical records, change their old ways of approaching care to be more team-oriented, tracking quality measures, tracking data. This is very new to many physicians. It may not be as new to some of the pancreatic disease specialists in centers of excellence in academic medical centers, but it's often a very new way of providing service and learning new skills. So there's a lot of disruption right now being caused by this move to value-based payment. It's a very difficult journey for many physicians, and that's honestly one of the reasons why we at Abbvie and the work that I'm doing on the policy team is really aimed at trying to help the physicians we work with have more information and resources to get through this very trying transitional time.
Right, right. Well, listen, does anyone else have any further questions or comments at all for Carol? Okay. Well, so we're going to wrap things up and keep your email inbox open. I'm sure you will, and stay tuned for. You'll get a Survey Monkey coming across that'll be asking you some questions about this and asking you to do some voting, so we can develop a manuscript with some input from all the people that attended Pancreas Fest to help us judge the quality of the scorecard and some of the things that we've come up with for developing the first attempt at trying to get a PQRS measure together for pancreatic diseases. In addition to that, we did submit an abstract to the American Pancreatic Association, and that abstract was accepted as a poster presentation at the APA in November, and we do plan on putting together a manuscript for that, and we also plan on having a meeting at the APA to discuss this further. But in the meantime, prior to that, we plan on moving forward with this and getting an endorsement from the AGA. I think there's a meeting in a few weeks with them. So that being said, I want to thank Carol. I want to thank Dr. Google and everyone else for attending tonight and taking the time out of your busy schedules for attending this webinar. I want to thank Caper for hosting this. It really went well, and thank you all for spending this time with us. And so we'll send another email out to let people know that next Thursday at 8 o'clock we'll have another one of these. So everyone, thank you, and get some rest. All right? God bless. Bye-bye.
Thank you, Dr. Conwell. Thanks, everyone. Have a great evening.
Bye-bye.